A 10-year-old boy is brought to the emergency department following a high-speed motor vehicle accident. He was the passenger in the back seat and was not wearing a seatbelt.
I don't remember anything. It's hard for me to breathe.
He has multiple bruises on his chest, difficulty breathing, and reduced breath sounds on the right side. His oxygen saturation is 86%, and his trachea appears deviated to the left. Physical exam: decreased breath sounds on the right side, tracheal deviation to the left, accessory muscle used during breathing, progressive respiratory distress. Question 1. What is your primary concern based on the clinical presentation?
The primary concern is tension pneumothorax, which is suggested by decreased breath sounds on the right, tracheal deviation to the left, and respiratory distress. The child's hemodynamic instability is also consistent with this diagnosis, requiring immediate intervention.
Question 2. What is your immediate next step in managing this child?
Take an X-ray of my chest and you'll find out everything.
The immediate next step is to decompress the tension pneumothorax. This is a life-threatening emergency, so a needle decompression should be performed immediately, without waiting for further imaging. A chest radiograph can confirm the diagnosis later, but immediate needle decompression in the second intercostal space, midclavicular line, is indicated.
What equipment and procedure are required to perform needle decompression for tension pneumothorax? Question 4. After decompressing the pneumothorax, what additional interventions are critical in managing the respiratory status of this child?
After decompression, the following interventions are critical. Chest tube placement, to provide definitive management of the pneumothorax and prevent reaccumulation of air. Supplemental oxygen. Titrate VO2 to maintain oxygen saturation above 94%. Positive pressure ventilation. If the child's ventilation remains inadequate, use positive pressure ventilation with careful monitoring of capnography. Waveform capnography. This should be employed to monitor the adequacy of ventilation in any intubated child, as hypercarbia can develop rapidly.
Question 5. The child's oxygen saturation improves to 92%, but there is still some respiratory distress. What additional diagnostic or therapeutic step would you consider next?
Given the remaining respiratory distress, a chest radiograph should be performed to confirm the placement of the chest tube and evaluate for other injuries, such as rib fractures or lung contusions. Arterial blood gas analysis could also help assess the effectiveness of gas exchange and ventilation, but this should not delay clinical decision-making. If needed, pediatric intensivists should be consulted for advanced ventilatory support.